everyone, and welcome to today's webinar, using patient access programs to support patient access to new and emerging technologies with Category 3 CPT code assignment. I'm delighted to see so many of you being able to join us today, and I hope you find today's session insightful and enjoyable. My name is Becky Johnson, and I'm the Conference Director with LSX Leaders in London. We have a large proportion of our own network joining us today, but also a number of new people to us. So very briefly, I wanted to introduce LSX. LSX stands for Life Science Executives. We're a community and network of senior life science decision makers across biotech, medtech, and health tech businesses, pharma companies, investors in the healthcare space, as well as payers and providers and other key stakeholders in the healthcare sector. We work to connect our network through digital content, such as today's webinar, digital reports and executive insights, digital roundtables, and other formats, and in more settled times, through a program of high-level, large-scale conferences, networking and partnering events, and showcases. Whilst these physical events can't take place, we're pleased to continue to be able to connect people and share the expertise of our community through digital formats such as this. We're delighted to be working with MCRA or MCRA, who are a leading advisory firm and CRO for the medical device sector. They have deep industry experience across regulatory, reimbursement, clinical research, healthcare compliance, and quality assurance. And you're going to hear from a number of the MCRA all-star team on today's session. I'd like to ensure we allow a minute or two for any latecomers to join before I hand over to Tonya for MCRA to kick us off today. So a couple of points to mention. We will have the opportunity at the end of the presentation to answer any questions that you may have. Please ask your question in the Q&A, and at the end of the presentation, we'll look to have them answered. If you have a question for a specific panelist, if you could start the question by referencing who this is directed to, so we can best answer it. And if you see a question that you had wanted to ask in the Q&A already, you can upvote for that question to show that you are also interested in the answer. Please do use this function and ask any questions at any time. One final thing. The MCRA team are all spread across different locations in recording this webinar, and the slides being shared from one of these locations, so you may hear next slide from some of the presenters as we run through. So that's it from me. Over to MCRA and over to you, Tonya.
Becky, thank you so much for the warm introduction. I'm going to share my screen here. Wonderful. Becky, thank you so much to you and the LSX team for allowing us to present this valuable information today. Before we get started, trying to advance the slide. Okay, there we go. Before we get started, we want to do some quick introductions of my esteemed colleagues, Dr. Joel Brill and Amanda Rhoades. Dr. Brill, would you please briefly introduce yourself?
Absolutely. Tonya, thanks so much. And folks at LSX, pleasure to be here. I'm a physician, internist and gastroenterologist by training, been involved in coding, coverage, and reimbursement for close to a quarter of a century, and looking forward to today's presentation.
Thank you, Dr. Brill. Amanda?
Thank you, Tonya. It's a pleasure to be here as well. I am the Director of Reimbursement and Market Access Execution with MCRA. I have been involved in the medical device space for over 15 years, and I have served many different roles. And I have been in the reimbursement space for quite some time now, serving in different capacities, and I'm looking forward to sharing them with you throughout my presentation.
Great, thank you, Amanda. And just to briefly introduce myself, I'm Tonya Dowd. I'm the Vice President of Reimbursement, Health Economics, and Market Access at MCRA. I've been in the reimbursement health policy space for just about 30 years. Recently coming from Johnson & Johnson, but have spent most of my career really working with new and novel technologies and assisting clients in developing cogent reimbursement strategies and executing those throughout the product lifecycle. So it's again a pleasure to be here, and we're very excited about today's presentation. Before we get started into the meat of the presentation, I did want to provide a very brief overview of MCRA. MCRA, as Becky stated, is a full service regulatory, reimbursement, market access, clinical, cybersecurity, and quality assurance and compliance consulting agency. We have offices based in DC and Hartford, Connecticut. However, under the current circumstances, we are remote. And we really take a holistic approach at MCRA, where we bring clients early on into the product life cycle, really helping them understand what their regulatory strategy is and coupling that with the reimbursement and market access strategy. And then I think most importantly, through our clinical research organization, ensuring that we are generating the right evidence for not only the FDA, but also the payer and provider stakeholders for market adoption. Today's learning objectives are really to understand the evolution of Category 3 CPT codes and their utility in establishing new technologies in the market. Also, we will review the importance of establishing a patient access program or reimbursement support program to support execution of your reimbursement strategy, and specifically for technologies with Category 3 code assignment. And then most excitingly, we have a live Q&A panel session with Dr. Joel Brill and Amanda Rhoades. If you've ever been to or have attended one of our reimbursement related presentations for MCRA, we always want to ground ourselves. You've heard us say this, we always want to ground ourselves in the 3 key pillars of reimbursement. And that is coverage. In other words, how a payer or third-party payer determines under what conditions a technology or procedure are medically necessary. Coding, really the identification of what procedure is being performed and or the diagnosis for that procedure, and then payment. And there are different payment methodologies based on setting of care, based on the type of payer we're speaking about, and provider contracts. So it's really important to consider all 3 of these concepts when you are establishing a reimbursement plan and strategy. And before we, when we really start developing the reimbursement strategy, we want to take a step back and truly understand what the intent of the technology is and what the business objectives are of that technology. Specifically, we want to understand and consider, again, as we're developing that reimbursement strategy, is this technology redefining the standard of care, or is it providing an alternative to the current standard of care? Secondly, does it truly fill an unmet need in the current care continuum for the specific patient population or indication? Thirdly, does the manufacturer want to obtain a premium price for the technology? That usually is the case, especially for new technologies. And does the technology improve clinical outcomes? And does it bring value versus the current standard of care? And how are we going to really generate evidence to support that value? Does it improve healthcare outcomes? And then finally, really important, what is the acquisition model? Is it a buy and bill where the manufacturer is selling the device to a provider, either a physician or a hospital, or is it a subscription model? So having all of these factors considered really delves into the considerations for the reimbursement and market access planning and strategy. And oftentimes we really want to, manufacturers come to us and really want to piggyback, if you will, off of existing reimbursement methodologies. So we often ask, are the key fundamentals are there codes available to adequately describe the procedure? And even if you've identified codes that you believe are appropriate, have those been validated through the appropriate processes and appropriate organizations? And we'll go into a little bit of that later. What are the assigned payments or payment methods for perhaps a piggybacking off of existing reimbursement methodologies? And is the current payment adequate for the physician and the facility providers? And thirdly, do the third-party payers have established coverage guidelines, and are they positive? And if these answers are relatively, or mostly no, we are really looking at truly the right pathway, that really a new reimbursement pathway, and establishing that for a client's technology. It's important before we get into the coding piece to understand at a high level the reimbursement methodologies or payment methodologies, specifically with Medicare, and which most of the commercial payers follow. So it's truly a bifurcated structure whereby the physician is receiving one payment, also known as their professional component, and the hospital is receiving a separate payment, also known as the facility component. And when we speak about a hospital, we are also including ambulatory surgery centers as well. In terms of the coding systems that are relevant, there are several, and we are going to speak specifically today about CPT, or current procedural terminology, for physician professional fees and hospital outpatient facility fees. But there are also ICD-10 diagnosis codes and ICD-10 procedure codes, in addition to HCPCS codes for device billing. For all intents and purposes, and this is just a graph to kind of depict this in a simple manner, ICD-10 diagnosis codes are relevant in all settings of care and with all different payment systems. Whereas for procedures, we have CPT codes that are relevant for the physician, and ICD-10 procedure codes that are relevant for the hospital inpatient, and CPT and HCPCS codes, again, relevant for hospital outpatient and ASC. But again, for today's focus, we're really going to be honing in on the CPT specific coding mechanisms and assignment process. So what is CPT? Again, it's the current procedural terminology, CPT, a series of numeric codes used to report medical services and procedures. They are a function, and they are actually owned and edited by the American Medical Association. And they are governed by the AMA CPT editorial panel. And again, they are used by physicians, clinics, ASCs, ancillary providers, and hospital outpatient departments. So what types of CPT codes are available? We have essentially three different categories. We have unlisted codes, and these are reserved, again, for new and emerging technologies if there is absolutely no other CPT code that exists. They have no payment assignment, and they are essentially a catch-all and a placeholder until a temporary code or a permanent code is established. They can be used immediately. And category 3 codes, again, which is really the topic of the conversation today, represent new and emerging technology. And it's important to understand that most technologies do begin first with an unlisted code and then move to a category 3 code. The category 3 codes do not need FDA approval or clearance or broad utilization, and they are often used in the early stages of a product life cycle during clinical trials and in early commercialization. They are used to track utilization and evidence for new technologies. There is no permanent payment assignment for the physician. However, there is an opportunity for payment assignment for the facility or hospital, and we'll talk more about that later. And they are assigned every 6 months by the AMA CPT editorial panel. Category 1 CPT codes are really thought of as the holy grail. Everybody wants to have for their technology or procedure a category 1 CPT code. Category 1 CPT codes are reserved for technologies that have broad society support. They are essentially accepted as procedures that are used and adopted and accepted in medical practice. They have permanent payment assignment because they go through something called the RUC process, which assigns values to the code for payment. And because of the RUC process that they have to go through, they typically take 18 to 24 months to establish. So you can see it's not a quick process. It does take time and a progression. So if we look at the criteria, which is really important for category 1 CPT codes, if you think about a new and novel technology that's first coming to the market, you're typically not going to meet a category 1 CPT code criteria. The professional society needs to support the code. The technology, of course, has to have FDA approval or clearance. The procedure needs to be widely adopted in the market by multiple physicians. You have to have up to 5 years, peer-reviewed published publications for that service. And 1 publication must be exclusive to the US population, and 2 of the studies can't be overlapping. And here's the minimal level of evidence for each of those studies. So again, Category 1 CPT codes require broad market adoption, clinical evidence, and most importantly, professional society support. If we look in contrast to Category 3 codes, they are truly for new and novel and emerging technologies and procedures. They are temporary 5-year codes with the expectation within that 5 years that we would move to a Category 1 CPT code. However, there is an opportunity for extension of the Category 3 code if supported by the society. So the criteria in contrast to for a Category 3, in contrast to a Category 1, is the procedure is currently or recently performed in first-in-human studies, and at least 1 society member or society supports the code, or the clinical literature exists in the English language supporting the actual or potential clinical efficacy, or there's at least 1 IRB approved study for the procedure being performed. A description of a current and ongoing US trial outlining the efficacy of the procedure service or other evidence that's evolving for clinical utilization. So again, it's important to understand that Category 3 codes can be established before FDA approval or clearance because that is not required, and they are oftentimes used, again, for tracking purposes in early studies. So if we look at the kind of the implementation and the trajectory of Category 3 codes, I think it's quite interesting to see. They were established in 2001 by the American Medical Association. And they were essentially established to broaden and to establish a coding construct for new and emerging technologies. What had happened in the early days is the commercial payers called out these procedures that had Category 3 code assignment as experimental investigational, so i.e. not covered in the payer policy. So you can see how the payer policies and coding are interrelated here. From a Medicare standpoint, the Medicare contractors or MACs across the country started to establish blanket non-coverage local coverage decisions or LCDs. So essentially you were put in the penalty box just by way of having a Category 3 code, and the onus was up to the manufacturer to dig themselves out of that penalty box with payer relations activities, evidence generation activities, and appealing claims on a case-by-case basis. So for over a decade, this trend occurred. And in 2016, there was a pivotal change with the 21st Century Cures Act, whereby the LCD process changed by CMS, requiring that each MAC provide a summary of evidence of why they considered that technology or those technologies that had Category 3 code assignment, and a list of sources of the evidence and their rationale for why. So in other words, the blanket non-coverage LCDs went away, and now they have to provide a rationale. So moving into today, 2021, we see they have really come a long way in a tiering type of coverage approach with United Healthcare in particular. This is a good example. They're actually tiering coverage for Category 3 codes in various buckets: non-covered, provisional coverage, possible provisional coverage, and no longer considered investigational, in other words, covered. So you can see the progression and how they really have come a long way. And they had, unfortunately, in the early days, really got a bad rap. They and we'll talk more about this with Dr. Brill during the discussion, but they were, termed the kiss of death, nail in the coffin. I could go on and on, but I think they've really come a long way in the recent years. So although they've come a long way, due to their temporary nature, and again, the use for new and emerging technology, a Category 3 code assignment may still result in potential negative coverage with third-party payers and negative formal coverage, necessitating providers to support the medical necessity of that procedure for that specific patient population or that patient on a case-by-case basis. And if we think about and look at the different criteria that commercial payers are considering when they're developing coverage policies, I won't read this verbatim, but this is typical technology evaluation center criteria which commercial payers look to establish coverage policies, either positive or negative. So the first three are typically met if a technology is FDA approved. The final two are a little bit more difficult because the technology must be proven to be as beneficial as established alternatives. And third, the last criteria is the improvement must be attainable outside the investigational setting. So calling for real world evidence and demonstrating the utility and health outcomes, positive health outcomes of the technology in a specific patient population with ongoing studies. So again, important to understand that the bar for evidence with payers is much higher than that for FDA. And on the Medicare side, they cover technologies and procedures that meet the reasonable and necessary definition. So is it safe? Is it effective? Is it not experimental and investigational, i.e. FDA approved or cleared? And is it appropriate for the Medicare patients and population? And I won't read this verbatim, but again, very similar criteria, but a bit different. So if we think about a product life cycle in the context of reimbursement and specifically coding assignment, if we think about it, we're looking at a 2 to 10 year product development R&D phase, moving into an IDE or clinical trial phase, whereby there is an option for a Category 3 code or establishing a Category 3 code to track claims, build clinical evidence, and garner society support during that trial time. And if you have an opportunity to submit for coverage with CMS during that IDE study, that's an opportune reason or rationale to obtain a Category 3 code. So you can populate the claims database and have that, and have the claims and have the utilization that you need. So in terms of moving to a Category 1 CPT code, either post-market specifically, you will need, again, to build that clinical evidence and to track the utilization and use of the technology and garner the society support to convert to the Category 1 CPT code. So again, there's utility in establishing that Category 3 code in order to move to a Category 1 if that is part of the strategy. And coverage and reimbursement support will be required during the Category 3 CPT code phase and in the early phases and even throughout a Category 1 assignment. So you might be thinking, Tonya, well, this establishing broad provider use, society support, and evidence before getting a Category 1 code seems really like putting the cart before the horse. And there are a lot of considerations for a patient access program and benefits. And I think it's imperative for technologies that have Category 3 code assignment to establish that patient access program or reimbursement support program to ensure that providers have the support they need to support the medical necessity for the patient in a prior authorization process and appeal if needed. And again, to support patient access to these new technologies. I'm going to hand it over to Amanda Rhoades, who is going to speak to MCRA's patient access program. Amanda?
Thank you, Tonya.
Sure.
There we go. Okay. So I wanted to start off by differentiating a call center and a patient access program. Typically with a call center, they simply do benefits verification, where a patient access program is going to exhaust appeals levels. And what we see with that typically is that's where you're going to see the standard of care adoption, is by exhausting those levels of appeal. Next slide, please. Next slide.
I know, sorry, I'm trying.
Okay.
Technical difficulties. It's not ever a good webinar unless you have technical difficulties, right? Oh, there we go.
Oh, there we go. Okay. So I think it's important here to mention that a patient access program is crucial for new and novel technologies. Especially, I think, MCRA's patient access program is, we have certified coders, experienced case managers, and patient advocates. And it's extremely important to have this part of your business plan, to have a very experienced patient access program to help your technology get to the next level. Next slide. So for here, taking the top-down, bottom-up approach to access coverage is sorry, I can't see all the slide here. It's just 1 second, it's my computer. There we go. If taking it by a case-by-case access approach. So for your patient access program, that's where everything starts, is by that patient case-by-case basis. And how do we obtain coverage? By getting those patient authorizations. That's how we're going to garner that coverage. So it's not going to happen overnight, but it's something that we will obtain by going through and getting those authorizations one by one. Next slide. Okay. So why is this the most powerful tool? I think something that's important to remember is this is something that is going to take time, as I just stated, and it's going to be a long haul. And you need to have a partner that is with you, that is going to work with your providers and the patients, and it's going to help you drive access. So you want someone who's going to be there to help bring access to the technology for broad market adoption. Next slide.
Trying again, sorry, it's delaying.
That's okay. I'll just jump ahead on my slide over here.
Yeah, I don't know why it's. Maybe I'll give the control to you, Amanda. I don't know why it's not going. There we go.
There we go. Okay. So with new technology, it sparks provider and patient excitement, which is phenomenal, but it also brings about challenges, as you can see on this slide. So how a patient access program can help is with utilizing their experience to submit concise information to the payer. And with that, that means medical necessity driven through the provider. And for this medical necessity, in that it's consistent messaging to the payer. Through this, it will drive the patient's authorization through that information for the payer to understand what that medical necessity is and how it will move forward. So moving forward with the authorization on that medical necessity, and for the economic piece as well, for the evidence piece, excuse me, for the evidence and medical necessity, that is how the utilization will drive forward, as well as the utilization and adoption. Next slide. So this is any process for a comprehensive patient access program. So I don't want to spend too much time on this slide, but for what we start with would be a benefits verification, a prior authorization, And physicians do have the ability to do a peer-to-peer review, and that's up to the provider. And for appeal levels, we can appeal a prior authorization, and for an appeal for a level 1. And some insurance carriers do have a second level of internal appeal. Not all do. And then there's an external appeal, which we'll go over on the next slide. And then we do work with post-claim denial appeals. So thank you. So kind of what does this look like, kind of the time frame? So for initiating a prior authorization, this actually can take up to 30 days. Insurance carriers do have up to 30 days to review a prior authorization. In a peer-to-peer, this depends on the medical director and the provider schedules. So they will schedule time to go over the patient's case and go over the medical necessity and the evidence that has been submitted by MCRA's team to the payer. A first level appeal, they actually can take up to 30 to 45 days. And this is once they have received the information and it has been uploaded into their system. So the payer, that's when their clock starts ticking, is once this information has been uploaded into their system. And again, that second level appeal, not all patients have this level of appeal with their insurance provider. An external appeal, these sometimes can go out to 90 days. I have seen some that have actually lasted longer. So these can actually take up to 90 days. So when they do go out to outside of the insurance company, so now it is outside of the insurance company and it is into something we call an independent review organization. So it is a physician that has a like specialty of your technology reviewing the information. So they're looking over all of the evidence, they're looking over the medical necessity of the patient, and so they're going to make a determination. So when it goes to these type of levels, the thing to remember is that this is actually costing the insurance company money when they go out to these appeal type levels. And if it is not overturned at the independent review or IRO level, the patient does have another opportunity to appeal at the state insurance commissioner level. So the patient is able to do one last appeal there. And if they are denied, they do have an opportunity to start the process over again. It's usually within the next calendar year. Next slide.
Oh boy. There we go.
There it goes. Okay. So what are the critical components of a patient access program? Here at MCRA, we customize everything to our clients and their technologies. So we develop standard operating procedures all along the way that we are doing this design and development phase. So I think that's something I really want to point to, especially since today we're talking about Category 3 codes, is the appeal strategy. This is something that we discuss at length with our clients, and we develop all of the documentation that is required and collect the clinical evidence. For the provider access portal, this is something that is online. It is HIPAA compliant. It's encrypted in real time. It is on a Salesforce platform, and it's something that you can access real time. And the next section here this is something that I think is probably the most important on this slide, is tracking utilization. So when we talk about tracking utilization, we will have determined with you data points. So, we can track any type of data point, which I think is very important. So we will go over what type of data do you want to track. We can track and trend anything. So when we go over this, it will be important because, as Tonya discussed earlier, something that you need to keep in mind is tracking utilization. So we're going to want to track the trends of payers, specifically the Blues plans, the Aetnas, the United Healthcares, because we'll want to, as we're working with you through MCRA, we're going to want to pull that type of data when you're going to look at, the utilization of your technology, when you're going to try to then submit for a Category 1 code. Also, the other part to look at this is we can look at your providers. So, which providers are utilizing our service? What type of volume are they submitting? What type of, we can see what type of cases. Are they submitting clinically appropriate cases? Are they on label? We have access to all this information, and we can report out to you any type of information that you want, as long as it is within HIPAA compliance. And then our program support, I think that, we do a fantastic job with our program support. And I think it's crucial to have this for all members of this process. So this includes internal stakeholders with our clients, the sales team, and also with the patients. We have wonderful patient advocates and case managers and certified coders. So the program support is absolutely crucial. Next slide. Thank you. So as I just mentioned, the case management, patient and provider assistance, and data analytics, these are just truly the components that make up a good program, and something that's going to help you along the way. So working with your technology and working through those case by case basis, working towards getting and improving the evidence, and working with the payers to seek coverage. So this is something that we do, customize for our clients. You will have your own designated phone and fax and email. This isn't something that just comes into a general line. This is all customized for our clients. You will have your own billing and coding guide. So these are components that I just don't want to read through all of this, but these are components that I feel are really important, that are something that is specific to a new and novel technology that is going to be needed for your sales team and for your providers. Next slide. Okay. So why a program is, why is it important? What are the elements that are needed to garner coverage? To establish medical necessity, and I feel like I'm a little bit of a broken record, but it's, when you're in the role that I'm in, I can't say it enough, establishing medical necessity and having that be a consistent message. That's where we can help. We have that letter of medical necessity. That's a template that we work with our customers on. And that's something that will help drive that consistent message to the payers that there is this medical necessity, that there is clinical guidance, clinically guided submissions for the patient's cases, utilizing the best clinical and economic evidence. We update our information. The information has to be updated as we learn why the payers are denying cases or they're approving them. We want to take advantage of that language and the reasons that they're either approving or denying. So we have to update all of the information that is being utilized with the payers. And then differentiating the technology from others that are in the same arena. So being able to differentiate the technology with the payers so that they can understand. So I've seen too many times that they just kind of lump it in with something else, but when we know that this is very different, it's it's new, it's something that it's just, you don't lump it in with something else that they just consider, oh, this is just kind of part of this, it's just we're going to throw it into this. No, we have to make sure that the payer is understanding that this is different. It addresses a whole different approach. It could be addressing different clinical needs of the patient. It could be addressing economic pieces of the puzzle. So we have to make sure that we are differentiating that technology. Next slide. Okay, thank you. So I do like this slide. It's busy, but it's very important. So commercializing, coming to a commercialization phase for new and novel therapies. So I think you kind of understand the crawling to the victory after the marathon. So it takes a long time, and that's something to remember. Is we're tracking the utilization, we're getting the clinical information that we need, we're getting the payer information, we're building that evidence, and I think that's what's so important to remember is we are helping you through a patient access program, case by case, get those authorizations, gather the information. We have to increase utilization to get that market adoption. So we are able to help you move on to that next step from the category 3 to the category 1. So and then it's not just we've reached it in a victory, the trophy. I do love the trophy, but there is ongoing management. You must always be monitoring your coverage with payers. So this is something that is an ongoing ongoing monitoring, and it does not ever end. So this is something to be aware of. So, and I don't want to skip over specialty society support. So I do feel that providers and patients help drive society support, and provider and societies help drive payer coverage. So I think that is something that is really important. And I hope what I just said, drives a message home, because you need support from all different levels. Okay, Tonya, next slide.
Great. Great. So we'll move in. Thank you, Amanda. We'll move into our panel session now. And Dr. Brill.
Hello there.
Hi, Dr. Brill. Amanda. Thank you so much, Amanda, for that great presentation. So, Dr. Brill, given your extensive experience in the CPT process and with HCPCS coding applications, and Amanda, given your current role at MCRA in leading the reimbursement execution service lines and really being in the trenches and understanding the nuances here, I want to get your perspectives on a few key points. So first question for Dr. Brill. As we learned today, category 3 codes got a bad rap in the industry, some referring to them again as the kiss of death. So in addition to the evolution we heard of today, their evolution, from your perspective, what else has changed and how might they be beneficial in a technology's reimbursement strategy?
Well, Tonya, first off, they have changed, and they've changed in part because people have recognized that category 3 codes are very effective for tracking, and that category 3 does not mean experimental, investigational, and the like. We have seen over the years a number of category 3 codes which have been successfully covered by commercial insurance, by Medicare, by other payers. And in part, that was because industry, physicians, specialty societies, entities like MCRA and others collaborated in order to ensure that there was a mechanism for tracking the performance of the code, ensuring that there is reimbursement for the code, coverage for the procedure, and ultimately leading to that code transitioning to a category 1 code or codes as the case may be. A lot has also changed. I think both of you pointed this out, that with 21st century cures, it became more and more apparent again that there was the need for this mechanism in order to show adoption of these new services, and that category 3 codes provided a mechanism for tracking adoption. And also is important is that while Medicare might not assign reimbursement to the physician under the physician fee schedule for category 3 code, Medicare oftentimes will assign a Category 3 code to an ambulatory payment classification or an APC, which means then that payment can be established to the facility, hospital outpatient, or ASC setting, for example, which goes a long way, again, towards helping to drive tracking, utilization, adoption, uptake, and coverage.
Right. Thank you. Absolutely agree. Hey, Dr. Brill, you mentioned some technologies that have successfully achieved reimbursement with Category 3 codes. Who would they be? What company?
Oh gosh. Well, you know, Category 3 codes have been around almost as long as at a time when I actually had hair on the top of my head, not hair on the bottom of my face. And there have been a number of services that have, I'll say, graduated from Category 3 to Category 1 service over the last decade or so's time. I'm just going to mention a few names. They're just representative examples. I mean, you have, for example, companies such as Vertos who have migrated, you know, for minimally invasive glaucoma surgery, Category 3, now migrating to Category 1. Prolonged cardiac monitoring services by iRhythm and others, as we know this year, migrated from Category 3 to Category 1. I said Vertus, I didn't mean to say Vertus. I really meant to say Glaukos. Sorry, brain freeze there. But you know, Vertus, I believe, is a company that actually has a coverage with evidence development under Medicare. And so Medicare covers that using a Category 3 code. Always helps when I get the part of the body right. Heart flow, you know, FFR evaluation, Category 3 codes for a number of years, covered by Medicare and a number of commercial payers. When TAVR procedures first started, they started as Category 3 and then quickly migrated to Category 1 codes. Those are just representative examples. There are others, but clearly, again, it's as I said, this combination of multiple stakeholders working together, developing literature, publications showing utilization, working with commercial payers, working with Medicare contractors also to drive coverage and reimbursement for the services.
Yeah, early reimbursement planning really is important.
Absolutely.
Yeah, absolutely,
and that's why the concepts around, you know, access programs like are so important.
Yeah, thank you. Dr. Brill, do manufacturers truly have a choice in which CPT code type they can establish? And if it is a choice between Category 3 and unlisted, what would you recommend?
Okay, well, there's two parts to your question, so I'm going to parse them out. Certainly, manufacturers have a choice whether they even wish to apply for a CPT code or not. Okay. One of the reasons why people may want to apply for a code is, as we said, for tracking purposes. Not only from a standpoint of whether the service was reimbursed, but there are databases that track codes that were submitted to commercial insurers and the like. So, you know, there's a need that some companies will see, you know, to be able to show evidence of utilization, adoption, and uptake. As we've mentioned a few moments ago, an advantage of a Category 3 code is that Medicare can assign the Category 3 code to an APC and payment to the facility, hospital outpatient, or the ASC setting. Whereas if you're using an unlisted code, Medicare A, defaults to the lowest payment APC, and B, doesn't establish payment for unlisted codes in the ASC fee schedule. Yeah. So that goes to the first part of your question, which is, do you have a choice? And as we know, CPT codes are created and developed by the American Medical Association. The AMA publishes in the public domain their criteria regarding what's needed for a Category 1 versus what's needed for a Category 3 code. And I think, Amanda and Tonya, I think we've all seen over the years that there have been entities, companies, especially societies, others who have submitted applications, sometimes submitting as a Category 1 code, and the editorial panel may have decided that it may, the request may not necessarily meet their criteria for Category 1, but they see the need for, again, a tracking code. And so the panel itself can take a Category 1 application and can revise it to a Category 3 application. So companies can ask, there's no guarantee. And again, thinking carefully about the criteria that the AMA publishes for establishing Category 1 and Category 3 codes, literature, utilization, utilization consistent with the prevalence of the condition being treated in the population, are just some of the important considerations that a manufacturer may think about when evaluating coding and, and if to submit a code application, what type of code to submit for.
Okay, thank you. So in your expert opinion, what can a company that receives and or pursues a Category 3 code proactively do to ensure they can support their physicians and allow patient access?
Well, I think it's crucial, as Tonya, as you and Amanda have outlined over the past half hour or so's time, that there's really a need to work collaboratively. And by that, you need programs that will assist both the healthcare professional as well as, of course, the patients with access to these new technologies and access, collecting data and utilization. You've talked about the appeal process, how to assist both the patients and the providers with the appeals. These all lead to helping to show utilization, adoption of the technology. It may help to identify certain patient niches, for example, of people who will benefit from a certain technology and And so these access programs become incredibly important because they are fulfilling many needs. But I'll kind of come back to the two most important ones. From a business perspective, data collection, but from a humanistic perspective, making sure that patients have the access to the new technologies and that can help them to improve their health and improve their outcomes. And that's why these PAP programs are so important.
Thank you. Amanda, we have about 30 seconds. So do you want to add anything to that in terms of what MCRA can do with their patient access programs to facilitate that?
Yes, I think, thank you, Dr. Burrell. You brought up some very good points. I think it's, something that I think we do a great job of with our patient advocacy and assistance with the customers is, we do offer, our certified coders. They are immediately available to answer any questions. And they help the patients when they have to formulate letters to send to the insurance companies. I don't know if anyone's aware of that, we do get to an appeals part of the phase where the patient is actually requested and sometimes required to complete letters where they have to basically explain why they feel they need the procedure. And so we have that ability to handle that type of requirements for the insurance companies. So we work with the patients and we work with the clients. And so we're able to answer any of those questions, especially from the providers. We get numerous calls from providers about the coding, so many coding questions, especially when it comes to Category 3s is, how do we code this? What should we expect for, reimbursement? And so our certified coders do a phenomenal job of being able to answer those types of questions, and of course, helping the patients get access to the care that they need with these technologies.
Great. Great, thank you, Amanda and Dr. Brill. I'm going to turn it over to Becky. I know we have a lot of questions from the audience, and I want to get to at least a few of them in the last 5 minutes. So, Becky?
Perfect. So yeah, I think you've probably touched upon some of these, so I'll try and squash a few together. But so the first one we have from Erin Keeney. It's for you, Tonya. Do you have a list of the best sources to gather the relevant codes and coverage details? I know you can look through Medicare and some private insurance companies, but I don't know if there's a list, obviously, that you can perhaps direct anyone to.
For coverage policies, specifically.
Yeah, coverage details is the
coverage details. Yes,
yeah.
Yes, we do subscribe. MCRA does subscribe to a program or service, which allows us to do ad hoc assessments on coverage policies, and also ongoing for a technology or a product category, ongoing with various coverage policies. So doing that surveillance with all payer types. So yes, we do have that resource in-house.
Perfect. And Mike Smith asks, reclinical outcomes, does the measurement allow for costed care pathways and allow for service redesign?
Dr. Brill, do you want to take that one? I'm not sure.
Becky, could you repeat that? Because I'm a little fuzzy on the specifics that he's asking about.
Yeah, sure. So reclinical outcomes, does the measurement allow for costed care pathways and allow for service redesign?
Oh, okay. All right. I think I'm going to try to answer that. I think I may understand that. So the answer is yes, possibly, and I'll explain why. Coding is simply a mechanism of tracking that something occurs. If one is tracking when a service occurs, an organization or an entity or a payer may also be interested in other information, such as how does the process flow work? How does that patient move through the system? Is there a value-based case to be made? For example, if I do procedure A, does that avoid the need for example, emergency room visits, hospitalization, hospital stays, pharmaceuticals, other treatments and the like? And so as you're collecting that information, again, by the use of a code or something of that nature, you can track, patient outcomes and the like, which may lead to, at a provider level, may lead to process redesign. And then at a payer level, not for Medicare, because Medicare can't consider costs when making coverage decisions, but certainly commercial payers, it could lead to, again, a value-based setting for having a discussion. The use of our technology leads to a cost offset.
Great, thank you.
Tonya, Amanda, anything else to add to that?
I think that's, I would agree with that. I think that's spot on.
The next question we have from Matt is, can you speak to the trade-offs of providing the support services directly for the patient or for the provider?
I can take that in a first part, and then I'll let Amanda take it. The patient oftentimes has more appeal rights under their benefit plans than the provider does. So it really just depends, honestly, on, and Amanda touched on this earlier, when we do a design and development process with our clients for the technology, we really need to consider the nuances and the reimbursement challenges and specifics of that technology. So it may be appropriate that the patient becomes the individual who's appealing their claim versus the provider. Amanda, do you want to add anything to that?
Yes, we do dig down into the weeds with the clients, over kind of what will be the patient pathway versus the provider, as Tonya just said. So we do have specific templates, if you will, for each.
Great, thank you. And sort of two that I'm sort of going to ask together. So one from Angela: can competitor technologies use the same category 3 code? And is there a benefit of establishing a category 3 code before FDA approval?
Joel, you want to take that one?
Sure. Category 3 codes describe this. Each category 3 code has a description, and oftentimes the descriptions are written in a manner that any technology that meets that description could be used to bill for those services. Sometimes codes in the laboratory field are written very, very specifically that, for example, you have to have a certain number of genes, and the genes must be included in order to bill for that service, whereas category 3 codes may be a little less specific in that nature. Is there an advantage to getting a code before you have FDA clearance? Absolutely. We've seen examples where, because there's such a backloading to getting a category 3 code. Let me give you an example. We're doing this seminar in the middle of May. The deadline for submitting a CPT application is June the 30th of 2021. If a category 3 code were accepted and approved at the upcoming meeting in the late September, beginning of October, that code would not be available until July the 1st, 2022. So as you're starting to look at your processes, you might be asking a question, for example, when do I think I'm going to the FDA? When do I think the FDA is going to approve my technology? Do I need this code in order to report, under an IDE trial or things of that nature? So all of these things may go into this mix of trying to make a decision a year ahead of time. Do I need a code? And do I want to be able to have a code available by the time my technology becomes approved? Because what you don't want to do is wait until the FDA approval comes and then submit the application, because then you're out, for a year or more until you have coding available.
Yeah, I agree. And just to add to that, you're essentially setting the foundation. And as I said earlier in the presentation, if you have an opportunity to have coverage, achieve coverage for the technology or the usual services provided for the technology during the IDE study, you need to have a category 3 code. And a Glaukos is a great example. We mentioned that earlier. Glaukos is a great example of that.
Perfect, thank you. And talking of FDA approval, we have a question here that says that we have a breakthrough device with FDA. Will we automatically have coverage and coding if we apply for the Medicare coverage program?
Oh, I'll take that one.
Yeah.
So for those of you who weren't aware, on Tuesday of this week, or 2 days ago, on the 18th of May, Medicare published that they are delaying implementation of the Medicare coverage of innovative technology, the MCIT rule, and they've deferred that out to mid-December, December 15th of this year's time. CMS published a number of reasons why they're continuing to reevaluate this program, but as a result, no, MCIT is not the law of the land, and no, just because you have a breakthrough technology, it's not a guarantee of Medicare coverage or payment or coding upon FDA approval at this time.
Good to know. And Kevin Conley has a question again about Medicare. So Medicare is paying for our new category 3 code, but only pays 10 to 20% of what is billed. What advice would you have around that?
So when someone says that Medicare is paying, the first question, of course, is is Medicare paying under the physician fee schedule, or in which case Medicare, with some very rare exceptions, does not establish a fee at the national level. I mean, so if it's a physician fee schedule, it means that a contractor, one of the regional entities that pay claims, is actually established a fee schedule. If we're talking about facility payment, then as we've mentioned, Medicare can establish payment under the OPPS, the Outpatient Prospective Payment System. So that being said, I'll give you two answers. If it's a facility payment issue, then you need to have a discussion with Medicare at the central office, the Baltimore level, and present them with information as to why you believe they've assigned you to an incorrect or inappropriate APC. CMS tries to use resource and clinical coherence when assigning technologies to an APC, and perhaps they didn't have information or the correct information that they needed in order to make that assignment. If we're talking about payment at a contractor level, in other words, payment under the physician fee schedule, then the question really comes down to having a discussion with a contractor, and some of the contractors are willing to take meetings. Some contractors only will take meetings when they have an open meeting to the public, but it's important to have a discussion with them. And again, to identify why you may have believed that the payment rate that they've established might not be appropriate. And there are a variety of methods, but again, looking at how much time does it take to perform the procedure? Can you crosswalk this to other procedures in terms of time, intensity, and complexity that Medicare has recently valued in the physician fee schedule? Does your procedure take twice as long as a corresponding procedure? So therefore, is the argument that you should be paid twice as much? Do you have an increased need for supplies in order to perform the procedure in the office setting? All that information, and others can be brought together in order to provide information, whether it is to a contractor or, for that matter, to a commercial payer, as to why you believe the fee schedule rate should be adjusted. Tonya or Amanda, anything else that you might add to that?
No, I exactly. I was going to say crosswalk is always a great option. And comparing it, what that means is comparing it to a procedure that is similar in terms of resources and time of the physician.
Perfect. So we've got two more, so I want to make sure that we get to them. So Angela asks, as we saw with the prolonged cardiac monitoring, the fee assigned was drastically lower and has caused a lot of discussion around the sustainability of that model. Is there any way to prevent this from happening?
I'm going to give that one to Dr. Brill. I saw that one. That's a good one, actually.
So
a lot of issues around that.
Medicare's been around for a few years, I think 50 years to be exact, or more. And the Social Security Act and the Code of Federal Regulations and other entities define the processes that Medicare uses in establishing payment. And payment under the physician fee schedule, there's three components. There's physician work, there's practice expense, equipment, staff, and supplies needed to provide the procedure, as well as professional liability. Medicare has made it clear in the proposed rule last summer, and what type of information and how they were looking for information in order to value and price these new codes. And because CMS didn't get that information in the manner that they wanted, they elected in the final rule to not establish payment, and they've left it up to the contractors to establish payment. So I guess the best way of answering the question is, you know, if you're dealing with a government agency and they have a process of how they want that information, you should be prepared to provide them with that information in the manner that they can accept, so that they can work that information through their processes, you know, their algorithms and their data analysis in order to come up with a payment amount. And I think the challenge is, you know, when we have new ways of doing things, new types of technologies, artificial intelligence would be an example. You still have to think about this question: how does CMS want this data in a manner that could help them to establish a payment amount? And that creates tension. And that also comes back to an earlier question, which is that there are at least 4, if not more, companies that are doing prolonged monitoring. And not all companies do the monitoring in the same way. Not all of them have the same AI algorithms or the same equipment, or, you know, may have the same cost structure, for example, for a disposable patch or the like. And so, you know, CMS is, again, when you have a service that is not unique to one company only, it does create challenges of trying to value things. And again, comes back to CMS. Once, you know, if you can give CMS the data in the way that they're looking for, it can help them to establish a payment amount.
And finally, I may have saved the most complicated to last, but it might be a whole new webinar. But we have an anonymous question of, what is the process for establishing a Category 3 code?
Tonya, did you want to take that? Or do
You go right ahead. Oh. I've done enough talking.
I could be a little.
This could be a whole nother webinar.
I could be, you know. I would start with really something very simple, which is in the public domain, and that is that the AMA does publish on their website general information as to the criteria for creating Category 1, Category 3 codes, creating laboratory codes and the like. And I'd say start with that information, because it's a good primer of understanding the basis for coding. And then once you start looking at that, I think then you can start asking the questions leading around coding, like what does a description of my procedure, of my product, my service look like? Are we talking about coding for my product, or are we talking about coding for the procedure that the physician performs using my product? Is this something that's described by an existing code or not described by an existing code? What's the literature? How does the literature come into play? Utilization, where is it performed? Who performs it? You know, what's the prevalence? What's the potential utilization of my procedure? And as you start going through that, you know, companies find that they will oftentimes reach out to, you know, to folks like, you know, Tonya and Amanda, and just basically saying, you know, this is sort of like deciphering the tax code. You know, it's not as simple as, you know, how much did I make? Write it down and send it in. I mean, these are very complex, I hate to say that, work of arts, and that, you know, it involves looking at not just some of the things that I just mentioned in the first few minutes, but also like looking at how Medicare policy may have an impact, what was previously evaluated in the past, what codes may have been present, may have disappeared, may have retired, or called sundown, what types of codes advance from a 3 to a 1 and why. And as you start going through that, you know, you start developing, I think, a more fuller picture of your question. So what does it take to apply for a CPT code? And Tonya, I really defer back to you, because of a lot of what you've done over the years has been around those types of questions as well.
Yeah, no, I appreciate that. Thank you. And, you know, I think the one most important thing I would impart on the audience is, I know we're way over, Becky, so I apologize, is the importance of garnering specialty society support in that process. And, you know, I would ask Joel, on a scale of 1 to 10, how important is society support in establishing a Category 3 or a Category 1 CPT code?
Well, I would say that it's pretty darn important, and that certainly it is really helpful if the specialty societies are supportive of your proposal, because if they're not supportive of your proposal, you'll have a very challenging, very difficult time in getting a code established. Now, that doesn't always mean that the specialty society has to be the one that is submitting the coding application, but you know, an old saying is that, you know, don't ask a question if you don't know what the answer is. So it's always helpful to know, you know, that for the specialty society or societies that perform your technology or procedure, it's really helpful to know what's their take, what's their opinion on this. You know, do their members utilize this? Is it something that's utilized by a subset of their members or only in certain centers like pediatric children's hospitals or cancer hospitals or things of that nature? So that when you're going in and having a meeting and discussion with the specialty society, it's helpful to them, for them to understand how this would be used and why this would be used, so that they can be supportive as your application, you know, moves through the process.
It is a process, and it's not just about sending in a document, you know, with your application. It is an absolute process. So you can certainly help through those for clients. I don't think Amanda may be having an issue with her. There she is. Okay.
Amanda, do you want to add anything or?
Uh-oh.
Oh, no, I think we've. Oh, okay. Well, thank you for that, Tonya and Joel, for answering that. I mean, I think, yeah, that's your next webinar right there, by the sounds of it. So
good segue into the next.
But a massive thank you to Amanda and Tonya and Joel for joining us today. That was incredibly insightful. I hope everyone watching enjoyed it as well and found it helpful. I know that everyone at MCRA would love to obviously discuss further with you. So if you do have any questions or queries, please do reach out to them. And I'm sure they'll be more than happy to obviously share their sort of wealth of knowledge and insights. It's also worth mentioning that MCRA are hosting 2 virtual invite-only forums in June around medtech devices and medtech diagnostics as part of the LSX's wider US CEO forum of events. So if you are a CEO within either of these spaces and would like to inquire about joining us, there's further information on the LSX website, and we will also put information about that in emails that we send out to everyone who's watching and is registered for the webinar when we send out the recording from today. So that's it from me. Thank you for everyone to joining us. Thank you again to Joel, Tonya, and Amanda. Have a great day, and I hope that we will see everyone very soon.